Marlon Mayo. Marlon Mayo received her medical degree from Baylor College of Medicine and completed her internship and residency in internal medicine at the University of California, Irvine. She completed her fellowships in gastroenterology and hepatology at the University of Texas Southwestern Medical Center at Dallas, where she is currently an associate professor in the Department of Internal Medicine, Division of Digestive and Liver Diseases. Dr. Mayo is recognized internationally for her expertise in autoimmune liver disease, particularly PBC. She has been the recipient of several grants in the study of pathophysiology. Why can't I say that? Anyways, pathophysiology, that's it, of PBC, and treated of its complications from the National Institute of Health. Sorry. She has multiple original scientific articles, review articles, and book chapters on cholestatic liver disease and its complications. Please welcome Dr. Mayo. Sorry about that. There's the clicker for you, just stay to the left of the podium.
And I'm going to take this off of the handle so we can compete with the party next door, because they can get rather loud. At some point, maybe we should all stand up and just start yelling, just to let them know that we mean business too. All right, so I'm going to be talking about itching, also called pruritus, in primary biliary cholangitis. And if you start to notice that you're itching during my talk and need to scratch, go ahead. That's a normal reaction. We expect that. Let's see. There we go. So exactly how common is it to have itching in PBC? Well, if we go back and look at the original trials of URSA, where URSA was tested against placebo in the efficacy for the treatment of the disease, we see that about 60 to 70% of patients with PBC have itching, and about 23% of those will say it's quite severe. Now, one important thing to realize, and I get this question a lot from patients, is that itching does not necessarily correlate with the disease severity. So you can have bad itching and still be stage 1, or you can have no itching at all and have a very advanced kilopascal reading on your MR elastography. It's also important to realize that itching, although we typically think, oh, PBC is associated with itching, it's not actually unique to PBC to have itching in liver disease. So other liver diseases will also get itching, including alcoholic liver disease, hepatitis C, etc. Although it does happen much earlier in the biliary diseases like PBC and PSC. Usually if a patient with hepatitis C or alcoholic liver disease is going to get itching, they will have more advanced disease or stage 4 disease. The itching itself is usually described as generalized, although when it first starts, it may start in just 1 or 2 little locations. It does have a predilection for the palms and the soles. So a common question that I often get is my itching from the liver disease or is it from something else? And generally, if people say that it involves the palms and the sole, that's a good indicator that it probably is coming from the liver disease. It has no primary rash, which means that a rash doesn't start at the same time that the itching starts. However, you can get secondary changes that result from scratching. So once you start scratching, you can get little scratches, excoriations, scars. You can see some, whoops, can we go back? Is there a pointer on this? There we go. See some illustrations here. You get these little red bumps that have crusts on top, and the skin over time will become dark, and these are all secondary changes. There's also a phenomenon we call butterfly sparing, which is where on the back you see a clear area in the middle of the back that's shaped like a butterfly. And really all that represents is the areas that the person cannot reach with their hand, that leaves a butterfly in the middle. However, if you go to the kitchen and pull out some implements and start scratching with those, you'll destroy the butterfly effect. The itching in PBC is characteristically worse in the evenings than it is in the mornings. It has a diurnal rhythm, and it's exacerbated by heat or pressure. So if you live here in Houston in the summer when it's hot and sweaty, if you're wearing tight clothes, that will make it worse. And one of the common ways in which itching really disturbs people's life is that it affects the sleep, and 74% of people report that it disturbs their sleep. And so that just compounds on top of the fatigue that they probably already have. And then it can cause social isolation or depression. Sometimes people don't want to go out because they feel that other people are looking at them like, why are you scratching? Do you have a contagious disease? And that's actually one of the things that's scored in the British scoring system of how severe your itching is. And then the course is very variable. It's very intermittent. People will have good days, good weeks, bad weeks. Over time, it does tend to generally progress, though, until the very advanced stages of liver disease, and then it magically goes away. And we really don't understand why it magically goes away in advanced stage 4. So this is Dantes Inferno. And he described relentless itching as one of the punishments that you receive in hell. And there's probably a good reason for that. It is one of a miserable condition to have. What I'm showing you here is the Italian artist Botticelli's depiction of Dante's Inferno, where, I don't know how familiar you are with the story, but basically, depending on what crimes or you have committed during your life, you go to a certain part of hell. And there are various circles or rings of hell. And it is the 8th circle of hell. Whoa, that just got louder. 8th circle of hell where where people who are traitors or liars are sent. And that is depicted in the close-up here at the very bottom. You can see, so each circle has a different punishment. So you see some people are destined to be upside down for eternity. In the 8th circle, which you can see here is depicted with all the creepy crawlies and bugs and snakes, that's where the traitors and liars go, where they suffer from relentless itching. And in fact, in some of the surveys of patients with PBC, they've described it actually as like bugs crawling or parasites or things crawling under your skin. So how can you measure itching? There are many different ways to measure it. Probably the oldest and most common one that's used by scientists is this box down at the bottom right called a visual analog scale, where you have a solid line scoring from 0 to 10 and you slash a mark to indicate how severe your itching is. If any of you are participating in clinical trials for primary biliary cholangitis, some of these might look familiar to you because investigators use them a lot. It's mostly, however, used in research. On the left, you can see the 5D itch scale, which was something we developed to get more at not just how severe the itch is, but what is the impact on your life. So it asks of things like, how is it disabling your sleep, your social life, how much of your body is it involving, questions like that. The glove that you see at the top there is an electric transducer glove. It has little transducers in each of the fingertips so that you can measure actually scratching activity. And the more modern version of that is these actigraphers, which are essentially like what the brand name Fitbit would be, where you can monitor your sleep at night. It tells you how well you've been sleeping because it measures your activity if you're rolling around in bed. Because if you're rolling around and having a restless night, then you are probably itching a lot. But however, most of these are used in research trials, and I think as a patient going into a doctor's office, you probably should it would be helpful to do some effort at quantifying your itching, but probably just simply on a scale from 1 to 10 would be sufficient to help your doctor. So liver doctors are unfortunately not very good at addressing itch during doctor visits. So this is a little study we did where we went to different clinics and recruited patients from the waiting room who said that they had chronic itch to fill out some surveys. And they didn't get any money, so there was no incentive for them to say yes. And you can see that in the liver clinic, only about half the patients who actually said they were having problems with itch was that recognized by the doctor. And what we did is we went back and we looked at the doctor's notes to see if they'd actually said anything about the patient having itching or addressing that with them. You can see that the dermatologists, not surprisingly, are really good at addressing itch at 99%. And surgeons apparently really don't care very much about itching because they were one of the lowest, down at about 20%. So the cause of itching in PBC is very complex. It's not completely understood. And I only have one slide on this because it does get very technical. But we do know that there are specific nerve fibers in the skin that can travel to the spinal cord, where they meet up with other nerves that then travel up to the brain stem, which relays the message to other parts of the brain. And there are neurotransmitters and there are molecules in your blood, in the skin, in your spinal fluid that are involved at every one of these junctures. And many of them have been shown to be related, or I should say associated, with itching and PBC. And so here's a fairly long list. So histamine, we heard earlier today, I think it was Dr. Gish says he likes to use antihistamines. There's not actually been any objective data that histamines play a role in this type of itching, but some people do say they get some relief with antihistamines. Opioids are not just the ones that you buy off the street or that you get at the pharmacist's office. Your body actually has natural endogenous opioids in it that is part of your pain tolerance system. And those are increased in patients who have liver disease. And we know that opioids in general can cause itching. We know that from old studies where when women went into child labor, they would actually inject morphine into their spinal cord as the epidural, and they would just start to itch all over the place. So we know that there are opioid receptors in the spinal cord that will cause itching. Bile acids are a potential culprit that's really received a lot of attention simply because they are made by the liver and they do accumulate in the liver when you have PBC. And I'll get into some of the treatments later, but some of the treatments that are directed at getting rid of the bile acids have actually improved pruritus as well. Progesterones and prostaglandins, these are more important probably in cholestasis of pregnancy, but also in PBC. And then there's a whole host of, like I said, neurotransmitters, serotonin, acetylcholine, the endocannabinoids that have all been shown to play a role in the itching, and moderation of them with pharmacologic agents in some cases has shown to be helpful. At the bottom, I've listed probably the new kid on the block, which is lysophosphatidic acid, which is also a neurotransmitter that can cause pain or itching, and autotaxin is the enzyme that produces it. And autotaxin is the only thing that's ever been shown to actually correlate the levels with the severity of itching in PBC. So people were excited when that was found. So this is a picture of some brain scans. Actually, this is a composite of brain scans from 6 different patients with PBC. And what we've done here is we've used functional MRI. Functional MRI is a technique where you can scan and it detects activity in the brain. So I don't know if you can see that there are red blobs and blue blobs, but the red blobs indicate areas of the brain that have become activated, and the blue blobs are areas that have become deactivated. And so these are patients with PBC and itching, and what we can see is that when they are itching, the red areas light up. And what was interesting to us in this study, and this is data that we did a few years ago. We haven't published it yet because it's very difficult to publish data on just 6 patients, and it's very expensive to do any more. But I think the data are very interesting nevertheless. But what we saw in terms of the areas that were activated is everything was in what we call the limbic system, which is a system of the brain that's associated with guttural responses, if you will. So the amygdala, which is associated with fear and getting used to fear. So clearly this is a noxious stimulus that patients don't like. The orbitofrontal cortex, which is where we integrate all our sensory information. This is involved with response inhibition. And so we presume this was the patients trying not to scratch as they were sitting in the scanner. The anterior cingulate is a big emotional center. So clearly this itching feeling is associated with a lot of emotional energy. And the posterior insula, which is where we have visceral sensory, so sensory of your internal organs. What was probably most interesting to us was not even so much what we saw was activated, but what we saw was not activated, or what wasn't activated. And that was there was no sensory cortex. The sensory cortex is what you would expect to see activated if you had just a sensation on your arm. If somebody touched you, if a mosquito bit you, if you had something there would be a corollary of that place in your brain where that sensation was recorded. So what that told us was that this was not just a simple peripheral sensation. This is more of a guttural response of visceral sensory things. So other visceral sensory phenomenon would be like nausea or dizziness or hunger pain or something like that. So this is just a little cartoon that was somewhat relevant. I imagine that if we did functional brain scanning on this little turtle and the dog for that matter, that we would see some pretty heavy activity in the orbital frontal cortex as they tried not to scratch. All right, so I'm going to spend the remainder of my talk talking about how to manage itch symptoms. And in honor of the royal couple who tied the knot this morning, I thought I'd share with you some pictures of them scratching. So congratulations to them. All right, so this first slide I've called, I don't like taking medicine, because I hear this a lot. And truthfully, there is no reason to take medication for itching except to feel better. It doesn't make any difference in the disease course or the disease outcome. And so most patients will start off saying, I don't want to take anything. What can I do besides taking medicine? And I should say that all of these things are expert opinion that have been offered by patients and that doctors have noted over the years. None of these are things that have been tested in randomized controlled trials. But I told you how heat and tight clothes will worsen itching. So the core opposite of that is that you should wear loose and absorbent clothes to avoid that. Dry skin will only make things worse. And so lots of lubrication on the skin, especially after showers. And I usually recommend people use the very thick moisturizer, the kind you get in a tub and you have to scoop out with your hand rather than the thin, runny stuff. Avoid things that can precipitate itching. So we talked about how narcotics can actually cause itching. And trim nails. So people don't realize this, but most of the scratching that does damage to your skin happens at night when you're asleep. And so people who have nails will wake up with, blood on the pillow and blood on the sheets because they have successfully scratched themselves quite a bit. And then along with the temperature modulation, it's important to keep your environment cool, but not overly dry. So I think we have some people here from Canada, and they always say their itching is worse in the wintertime because everyone's inside and it's very dry. But it's not the coolness, it's the dryness that makes the itching worse. And for our showers, if you take a hot shower, that will increase the circulation to your skin and actually makes the itching worse afterwards. It might feel better when you're in the shower, but as soon as you get out, it will be worse. So I see a lot of nodding, like, yes, I've noticed that. So we recommend that at least at the end of the shower, you cool off with some more tepid water to bring the temperature of the skin down. And then for people who are really just having a spot that's, bugging them intensely, I recommend they just stick an ice pack on it to try and distract them from the itching. And then there is some data that sun exposure, at least in a controlled manner, can help with itching. This is a favorite of dermatologists. They use it for all kinds of other itchy skin conditions. It does inhibit the release of histamine and proliferation of mastocytes, which are cells that also produce itching. So it's useful in other itchy skin diseases for that reason. It also gets bile acids and uremic salts, which are the ones that accumulate in kidney failure that make you itch, from the skin and increases the bile acid excretion out the kidneys. So it does help lower the bile acid in your skin. Whether that's relevant or not, we're not sure, but it can't be a bad thing. But there's actually very few studies or actual data looking at how well this works. You can see the one study was only 6 patients that showed that it works. Most people, if they do this, have to go to the light box at the dermatologist office about once every 2 weeks. So what about URSO? So the data that we have would indicate that URSO doesn't really have an effect on itching and PBC, and I've heard patients say one or the other. It's not uncommon for patients to say when they first start URSO, it can actually increase itching, but with time that will go down. Unfortunately, the data from all these trials, which were the initial URSO licensing trials, really only counted how many patients either had pruritus or didn't. They didn't carefully grade like how severe it was. So I think what we can say is it doesn't make itching go away, but we don't have accurate data on what it does to the severity of itching, really. Okay, so it's bad enough now for me to take something. When all those lifestyle changes don't help, what can you do? And I think you've seen versions of this yesterday and today in one form or another. This is the sequence of prescribed medications that is recommended by both the American Association for the Study of Liver Diseases and the European Association for the Study of the Liver. I will say that the order that these are presented is based really on the quality of the data and the safety of the medication and how long they've been around. It's not based on efficacy. So it's not like the top one works better than the next one, which works better than the next one. Like I said, it's exclusively based on the quantity of data that we have. I think in real life, what many physicians do is sit down and say, these are your options, lay them on the table, and let patients pick which side effects they're willing to deal with and which ones they're not. So I think you could start at any point in this algorithm, but we'll go through it in some detail. First step is to use a bile acid sequestrant like cholestyramine or cholestyramine. If that doesn't work, then rifampin, which is a tuberculosis drug. And then if that doesn't work, try opioid antagonists. And if that doesn't work, try a SSRI. So this table gives you some details about how we give these medications and what the potential side effects are. I see people taking pictures. Go ahead. I don't care. So cholestyramine, we typically give 4 to 16 milligrams a day. It's a powder, so that's 1 to 4 scoops a day. The potential side effects for that one really are GI. This is not a drug that gets absorbed, so the only side effects you can have really are gastrointestinal. And it can cause bloating and constipation. A lot of people don't like the powder preparation. It's difficult to dissolve. I've been told it's like trying to put beach sand in a glass of water and then drink it. I've also heard that if you put it in a shaker and shake really hard, that works better than trying to stir it. But the main potential issue with that is it binds other medications. It's meant to bind the bile acids in your gut, but it will also bind to other medications. And so if you take a lot of medications, it's difficult to schedule this with enough room on either side of the dosing not to bind your other medicine. Cholestyramine and cholcevolin, which I don't have on here, is another bile acid binding resin. Work similarly, but you can get in a pill form, which some people find a lot easier to take. Rifampin, we give it a dose of anywhere from 150 to 600 milligrams daily. There are studies using all those doses and several in between. And most people don't have any side effects from rifampin, but it's possible that they could get a rash, a fever, nausea. Elevated liver enzymes is the one we look for very closely. It also can affect metabolism of other enzymes, of other medications. You see the major ones listed there, really just Coumadin and Prograf for the ones that we probably worry about in this population. Naltrexone is, there are several other versions of opioid blockers that you can use. Naltrexone is the easiest to give. We generally use 25 to 50 milligrams daily. And the main potential side effect there is once you cut off your native opioid system, you often don't feel so good. You feel like you're going through withdrawal. And so patients can have nausea and a flushing and dizziness, and their blood pressure shoots up. Or if they are prone to chronic pain or back pain, that can get worse. And then finally, sertraline, which is an antidepressant, but has also been shown to have an effect in itching, can be given. And it has probably, I think, the least side effects of all of these, but it can cause some loose stool or mood changes. Usually the mood changes are for the better, but sometimes they're not. All right, so what's new? So there are clinical trials going on for itching and PBC. There are 2 that I'm aware of that are going on right now. So one is only in Europe, in the Netherlands, and that's the effect of bezafibrate on cholestatic itch. Bezafibrate's, have you all heard about bezafibrate at this meeting already? Yesterday? Okay, good. So it's a medication we don't have in the United States, but I'll show you some data about why they're interested in using that as an itch drug. And then the second clinical trial is the Glimmer trial, which is both in the United States and Europe. And since we're in Texas, I'll tell you that the 2 Texas sites are San Antonio and Dallas, if anybody's interested. So these are the results from the French multicenter bezafibrate study that were recently presented. These are patients with PBC who had elevated alkaline phosphatase despite taking urso, and so they were given bezafibrate on top of that. And what they saw was really pretty impressive when it came to the itch score. You can see the placebo in red didn't change very much, but the itch score dramatically dropped almost 70% in patients who were taking the bezafibrate. So this was really impressive, and that led them to then create the trial that's going on in the Netherlands. I will say that there are other countries that have done bezafibrate studies. There have been a lot in Japan. There's been a meta-analysis of several of those trials, and the meta-analysis of all those trials did not show the same impressive effect on pruritus. So I think we do need that study from the Netherlands to really see. It's going to look specifically at itching to answer that question for us. Now, the other study, the Glimmer study, that is a medication that is designed to block bile acid reabsorption from the gut. So just to give you a little primer on bile acid metabolism, you know, bile is made by the liver. It's the digestive juice that our liver makes, and it travels down through, once it's made, travels down through the biliary tree. This figure doesn't show you all the branches of the tree, but starts at the tiny little branches and travels down, finally exits between the right and left main duct, and then joins into the common bile duct, where it's delivered to the intestine, where it can do what it's supposed to do, which is to digest your food. Of course, with PBC, what you have is inflammation and damage to the tiny little ducts up in the liver, so a lot of that bile cannot get out of the liver. But after the bile mixes with your food and helps to digest your food, it's actually reutilized. So the liver is very good at, you know, reduce, reuse, recycle of the bile acids. 95% of your bile acids get reused. So after they get into the intestine, they travel all the way down from the upper small intestine to the lower small intestine, and then they get reabsorbed, and they travel back to the liver, and they get used again. So what these new drugs do, or the one that's being tested in the Glimmer study, is they actually block that receptor that takes the bile acids back up. So what happens is you end up excreting them in the stool, and the total level of serum bile acid, the total level of bile acids in your body goes down. And this is the preliminary data that was shown with that particular agent, looking at how well it helps to reduce itching. This is just 3 different scales you can use to measure itching, the 1 to 10 scale, the PBC-40, or the 5D. And you can see that the placebo, this is the baseline, and how far it goes down is how far the itch is reduced. So you can see placebo is not bad. When people think they're taking something, their itching actually gets a little bit better. But when you're taking the real thing, it actually gets a lot better. And so they had, you know, pretty even reduction in itching, no matter which scale they used to measure the itching. So that's what led to the follow-up study, which is the Glimmer study. And those are the 2 itching trials that are going on. I just want to say a final word about itching with obeticholic acid. So the new medication that's out there is for adjunctive therapy to be given on top of urso in people who don't respond well. It's well known that a potential side effect of that drug can be itching. So just to let you know kind of how common and how bad. This is the data from the POISE trial, which was their licensing trial. And you can see that in the placebo, they still had, you know, 38% of people who had itching in the placebo group. But it certainly was more common in the groups that were taking the obeticholic acid. And in fact, the 10 milligram group, it was 70% of people who had itching. However, it wasn't bad enough for people to stop the medication. Only about 10% stopped the medication, even in the higher dose. But these are also highly motivated people who are involved in the clinical trial. I would submit that probably all of you all in this room, because you're at this meeting, would probably fall into a similar group. But in the general population, people tend to give up a little bit more easier. And then the severity of the itching that they may get can be mild, moderate, or severe. This is the timeline that shows you what happens with the itching on that medication. You can see that within the first 2 weeks, the itching starts to appear, primarily, again, with the 10 milligram dose. But then over time, people adjust and it comes down. And in fact, by the end of a year, it's not any different, really, than the people who are on placebo. Because of this better tolerance of the titration group, which is a group that went up to just 5 and then increased to 10. They increased to 10 here. It was was better tolerated with respect to the itching, which is really the main reason why the drug is prescribed that way, starting at 5 milligrams and then increasing to 10, because it improves your itch tolerance. And then finally, if medications fail, there are some procedures that can be done. These are rare, but they can be done. One is you can do plasmapheresis or MARS, which is kind of a dialysis of your blood to clear out all the proteins and bilirubin and bile salts, and that can be helpful. MARS is not FDA approved, so it's only available in a few locations as a research option. There's nasobiliary drainage, where you go get an endoscopy, and the endoscopist goes through your mouth, down your stomach, into the small intestine, and then puts a tube up into the bile ducts of your liver, and then they drain it all the way out, and the tube comes all the way out your nose, like that. So her bile is draining out of her nose. And that's ew. You don't have to be that way for the rest of your life. People just do it for, a few days to try and get some relief. And then it will last for, a few weeks and then come back. And then finally, liver transplantation. Every year there are just a very small handful of liver transplants around the world that are done just for itching that doesn't respond to anything. And this is my final slide, just to let you know that even though going to itchy and scratchy land is probably not your first choice in terms of vacation, if you should find yourself there, you should know that you're not alone. There are many other people there. And if you advocate for yourself and make sure your doctor pays attention to the itching, there are many options that can be used to treat it. And there are also many good options that are under development that hopefully will be coming out soon.
First off is use of daily sunscreen with zinc. Will it make a difference?
So the question was, should you use, stay away. The question was, should you use daily sunscreen with the zinc? And so I would say yes. They're not, the sun exposure is helpful. It would probably, you'd get more benefit to use sunscreen without the zinc. If you wanted to get a little bit of extra, UV therapy in for your itching. But clearly, I can't stand up here and recommend that everybody go sunbathe and not use sunscreen, because the risk of skin cancer, is real, and it's great. So I would say for someone who has really bad itching, probably sunscreen without zinc. Allow some of the UVB rays to get in. Okay, so then the question is an alternative to hydroxyzine. So hydroxyzine is an antihistamine. Or is this alternative to hydroxyzine?
Yeah, prior physician spoke about.
Okay, it goes on and on and on.
Yep.
Okay.
Is there cardiac issues to be concerned about with hydroxyzine? Do you know, an alternative?
I mean, hydroxyzine is an antihistamine. In my experience, it has very low efficacy, but some people say it can help. If somebody has cardiac arrhythmia problems to begin with, it probably wouldn't be my first choice, but someone who doesn't have any conduction abnormalities in their heart should be fine. I don't think there would be any reason not to use it. I'm not sure why this particular person was told not to use it. But there are other versions of antihistamines that can be used as well. And then that whole list of medications we went through.
Okay, great. And I had a quick question on, you mentioned serotonin and kind of the effect on that. What about melatonin? Does that have any effect? Does that affect serotonin?
Right. So the question was, what about melatonin? And the only study I'm aware of was one that used melatonin to actually reverse people's sleep-wake cycle. And to see if the itching, which we know gets worse at night, would switch also or not. And in fact, it does switch. So if you have someone who's like a day shift or a night shift worker and is up all night and sleeps all day, their itching is worse in the day. But in terms of being used to treat itching, I would think it would just put you to sleep.
Well, thank you. Thank you
Sure.
for your Thank you. Thank you, Dr. Mayo. Appreciate that.